these branch chain proteins, they're the ones that are gonna cover these static charges on the cell membrane and make the cells stack on top of each other, giving you the Rayleigh formation. By the way, the negative static charge, if you are really interested, is known as the zeta potential, Z-E-T-A, zeta potential. So this static charge, this negative static charge that you see over here, this is from the carbohydrates, don't forget, like I said again, and they repel the cells, but with these plasma proteins they are going to stack on top of each other. So now, knowing all of this about the plasma proteins and the stacked red cells, I would like to talk to you about a very important clinical aspect, which is the erythrocyte sedimentation rate. Okay, so erythrocyte sedimentation rate. This is used a lot in the clinics, okay, and you should know how to use this. So what the erythrocyte sedimentation rate is we take your blood and we take these tubes over here, right, vertical tubes that are held in these stands over here. So there are these stands that hold these tubes in place like this, so it's stabilized over here like this. And what we do is we just keep your blood over here in this tube. There are two different kinds of tubes. One is the Westergreen's and the Wintrob's tube. So you have two different kinds of tubes of different lengths, and the values are different for them. Anyway, but now look at this. You will have your blood stacked over here, and this blood is anticoagulated. So you take some blood and you mix it with some anticoagulant, like trisodium citrate, for example, which chelates your calcium. So now your blood's not going to clot, like I said. So your RBCs are floating around over there, and we leave this blood over there just in exactly vertical tubes like this, either the Westergreen's or the Wintrob's tube. And the Westergreen's tube is like 20 millimeters in length, 200 millimeters in length, that's 20 centimeter. And the Wintrob's tube is around 11 centimeters in length, or 110 millimeters in length. And the Westergreen's tube is around 2.5 millimeters in diameter, and the Wintrob's tube is around 3 millimeters in diameter. And so there are different values over here. So what's going to happen is these RBCs, they will start to get coated, with these proteins, these branched proteins like fibrinogen, and a little bit of contribution from globulin, and almost very little, negligible contribution from albumin, unless there's a condition where albumin levels rise drastically in the blood. And then numbers can help in overcoming the lack of branching for albumin. So what's going to happen is this negative static charge, the zeta potential, is going to be covered by these branched proteins over here. Fibrinogen with its 6 branches, globulin, you think of immunoglobulins, you see that they have heavy chains, 2 heavy chains and 2 light chains bound by disulfide linkages. Can you see that? So this is going to coat your cells, just coating it. And like I said, it's like makeup, it's foundation. It's going to negate this static charge, this negative static charge, and it's going to cover it up so the cells start to stack on top of each other. Now the cells, they keep stacking on top of each other, and then they start settling down. So these cells, they start to settle down, and what you get is a little layer of, this is the red cells over here, but you could see there is a small layer of no blood cells over here, no redness. It's just plasma at the end of a fixed unit of time, which is 1 hour. So what we do is we will wait for 1 hour, and we will see how much of this level of plasma has formed at the end of 1 hour. How many millimeters have your red cells settled at the bottom? This is not clotting. I'm repeating again. This is not clotting. What is this? This is Rayleigh formation. Rayleigh formation. Do not pronounce it as Rolex. Rolex is the singular form, but Rayleigh is the plural form. Because we're having many stacks of cells stacking on top of each other, like a stack of coins, which you play with your carom board and all those other games you play. So you stack them up like this over here. So they stack up and they start to settle down, and you get a clear layer of plasma. Now, the more stacking, the more the rate of stacking, the much more is the level of plasma that is formed, the more settling takes place over there, and that is directly proportional to the levels of your branched plasma proteins. Okay, so the plasma proteins with a lot of branches. Okay, so why are we doing this? Because if you have more plasma proteins, you will have an increase in the Rayleigh formation and an increase in the erythrocyte sedimentation rate. So you can guess, you can get an idea of the level of branched plasma proteins like globulin and fibrinogen. Now, why do we want to know this? Because these plasma proteins, especially these branched ones like globulin, what do? They increase in various inflammatory conditions. So when you're sick, you have inflammation, whether it is infectious or non-infectious type of inflammation, you are bound to have an increase in the erythrocyte sedimentation rate. So you can find an increase in the rate of sedimentation above the normal for in certain conditions. For example, especially you'd like to think of conditions like tuberculosis. This is a chronic infection, so you'll make more antibodies to try and fight this condition, and those antibodies also tend to coat your red cells in the ESR test. And if you look at other conditions like cancers, like your Hodgkin's lymphoma, think of Hodgkin's, and many more cancers, but especially Hodgkin's. And then you've got your other infections, especially other causes, inflammatory causes like autoimmune conditions where the body attacks itself. Autoimmune conditions. So these autoimmune conditions, for example, have you heard of rheumatoid arthritis, where the immune system starts attacking synovial joints, or systemic lupus erythematosus, SLE? So here the immune system just attacks almost every cell, from your brain cells to your blood cells to your you name it, to your skin, to your lungs, everything gets affected in SLE. Like lots of problems. These patients have characteristic butterfly rash. So on their face, this is their face, the sun exposed areas like the forehead, the nose, and the cheeks, the zygomatic bones, they have this kind of a red malar rash over there, a butterfly rash. It's kind of shaped like a butterfly. Okay, I'm not a good artist, but this should be enough to get you the idea. There's your guy's eyes, that's his face. Okay, he's not so happy actually, he's going to be sad. And this is usually seen in women, especially of African American descent, of black descent. So those people will have this rash. Their hair tends to fall off, so there'll be patchy hair loss that is seen in these people. Their kidneys get affected because the immune system is destroying it. So again, you're making antibodies against the various cells in your body, and these antibodies are globulins, which are branched, as you could see. So rheumatoid arthritis, lupus, these are all the various conditions that will cause an increase in the ESR. Okay, you can think of other autoimmune conditions off the top of my head. I would say Hashimoto's, thyroiditis. All these conditions are autoimmune conditions, and they can mess with your health in the long run. So TB, cancers, autoimmune conditions, and other non-infectious causes like gouty arthritis. Gout is where you have so much of uric acid. So what is uric acid? It's the breakdown product of purines. So you have these purines from your DNA, and when you destroy these purines, when you digest them, destroy them, they get converted to uric acid in the body after you metabolize these purines. So from purines, right, they're part of your DNA. Right, so these purines, they break down into uric acid, and that uric acid tends to sometimes get stuck in the joints. They make little crystals in the joints, and those become a big problem because those sharp crystals damage the joints, especially in the toe, in the big toe. So we call it podagra. Right, so you get this inflamed toe, and this gets worse especially in people who have who consume a lot of alcohol. So you consume alcohol, and it messes with the excretion of uric acid from the body, and by doing this, it's going to cause the accumulation of uric acid in the body, and you will not be able to excrete it. So it starts to crystallize, and it sticks in your joints and many other parts of the body, not just joints, but joints are primarily affected. So you can even get uric acid stones in the kidneys that form because of this. You know, it's not a good day to have too much of uric acid. Some people who have especially alcohol mixed with food that has a lot of purines, like cod fish, you know, the cod fish has a lot of proteins in it. So very unhealthy balance, an imbalance of alcohol and red meat and cod fish, and staying in cold weathers, it causes these crystals, and they can induce an inflammatory reaction in the joints that are quite painful over there. So they'll need some treatment for that. Anyway, so you can see an increase in ESR in all these various conditions over here. The ESR, as you could see, I said, it is subject to branch chain proteins, okay, the rate of ESR. But there are other factors that do play a role over here, like your viscosity of blood. Don't forget, viscosity is another important factor. So the more viscous your blood sample is, like viscous meaning thick, so conditions like polycythemia, where you have more than 6 million cells per ml, 6 million red cells per millimeter cube of blood, this is going to cause what? Your blood cells to move slowly, because viscous fluids means the particles are moving slowly in high viscous fluids. So this high viscosity of fluid seen in polycythemia, there is high viscosity in polycythemia. So this high viscosity means the RBCs don't get a chance to meet each other quickly, to stick to each other quickly, because they're moving slowly. Think of it that way. So this is going to cause a reduction in your ESR, erythrocyte sedimentation rate. Whereas if you have this one, anemia, that is going to cause a decrease in viscosity, because your blood is thinner. Decrease in viscosity. So less viscosity means the red cells are moving faster and bouncing into each other, and more often sticking to each other, stacking on top of each other, making the Rayleigh formation that we talked about over here. So this is going to increase your erythrocyte sedimentation rate. So anemics get this one, higher erythrocyte sedimentation rate. However, there are some anemias again which this doesn't apply to every single anemia. All right, so when we talk about anemia, you'll realize that there are different kinds of anemias over here. So for example, there's one important feature we use to describe an RBC. This is an RBC index. This is called mean corpuscular hemoglobin concentration. So what happens is your mean corpuscular hemoglobin concentration tells you how much of your RBC's cytoplasm is hemoglobin, and it's usually 33 to it doesn't cross 34%. Okay, it's supposed to be around 33%. Oh, it never crosses 34. It's very unlikely to cross 34 over there. So if you have less hemoglobin in the cells, like in iron deficiency anemia, for example, your cells are going to have very little hemoglobin, even in thalassemia. So your MCHC might fall in those conditions. So what's going to happen is your MCHC is what do you say? It's around 33 to 34%. That means 33 to 34% of your RBC cytoplasm is hemoglobin. It's got hemoglobin molecules. This is the main constituent, remember, of your RBCs. So this MCHC, if you have higher MCHC, your cells tend to settle down faster. Okay, they tend to fall faster. And this is going to increase your ESR. So this again influences your ESR. Red cells with higher MCHC tend to fall faster than those with normal or low MCHC. So they tend to fall faster over there. Okay, so this kind of thing is very important to know. And there's a condition where cells have weird shapes. We call this poikilocytosis. So there's too much of variation in the shape, for example, sickle cell anemia and all that. So if you have sickling in the cells, we'll talk about sickle cell anemia. You might be aware that there's a small point mutation, and the globin chain, one amino acid called glutamate, is replaced by valine in the 6th position of the beta chain. We'll talk about that. But you must have studied about this in school. So this causes the sickling of cells, and it's unlikely that these sickle cells can stack so well on top of each other. As you could see, there's a variation in the shape. So Rowley formation becomes less over here, poikilocytosis, and that is going to reduce your ESR in those situations. Okay, variation in the size of the cells, we call it anisocytosis. Again, changes in the size of the cells. So if you have for a big cell and a small red cell, and a big cell and a small red cell, this can be seen in conditions like what we call dimorphic anemia. Dimorphic anemia, like where you have iron deficiency, because iron deficiency anemia makes small cells, and vitamin B12 deficiency or folic acid deficiency makes big cells. The cells become big. So when you are low on iron and B12 and folic acid at the same time, then you are going to get this dimorphic anemia, and that is again going to reduce your ESR. So bottom line, what are we using ESR for? What are we doing all of this for? So ESR is not used for diagnosis, If you send a few lab tests and it comes back with a high ESR, you don't suddenly tell a person, oh, you have cancer, or oh, you have tuberculosis. They would have a very bad day. And what if you're wrong? So nobody says, oh, you must have this or that. Don't do that. You're asking for trouble. So what are we doing ESR for? This is to tell you the prognosis of the disease. Prognosis. So what do you mean by prognosis? So person comes with tuberculosis, okay, and you start treating him with medication, for example. So he's come to your clinic or to your OPD, and you found that he has tuberculosis. You start him on treatment. So person comes with TB, his ESR is a certain number, it's high already. Now as you start treatment, RX is the sign for treatment, then you monitor him over some time, and you see that his ESR is reducing slowly. So his ESR is getting down and down. That means his health is getting better. The tuberculosis is coming down, the antibodies are reducing in the blood, and because you're killing all those microbes, those mycobacterium tuberculosis bacteria, and he's getting much better. So that's good. But supposing a person had TB with high ESR, you give him treatment, and he doesn't get better. Maybe he's not taking his medication on time, or maybe he has a drug-resistant form of tuberculosis. That's the antibiotic resistance. So you know that he's not responding to the medication, and maybe you might have to try some other special courses of antibiotics in these people, in these patients over here. So that's why we do this. We do this for prognosis. Even for all these other conditions, is a person's lupus or rheumatoid arthritis under control? Check the ESR. Are there other tests that people can do? Yeah, there are, which tell you if there's inflammation in the body, like C-reactive protein, CRP, C-reactive protein. So this is a protein made by the liver, and whenever you have some inflammation in the body, like pneumonia, actually this was built to combat pneumonia. Your body makes this protein to clump and to hold on to your Streptococcus pneumoniae. So it helps in fighting pneumonia. It's not an antibody or anything, it's just a special protein for that, but it's secreted in other inflammatory conditions. So these inflammatory conditions you see over here, heck, even COVID-19, when people had COVID-19, they used to look at the C-reactive protein level, CRP levels over there in those people to see their prognosis. High CRPs meant bad prognosis. And even like most people who generally don't have any disease but live an unhealthy lifestyle, where they eat a lot of like I said, they smoke, they drink, and they consume a lot of unhealthy amounts of junk food and red meat, their CRP levels might be high, and that reflects a risk of cardiovascular disease. So you can also tell if a person's living a good life, or if they need to detox a little bit from their lifestyle and bring some harmony and balance to the way they eat, get a little grounded and a little one with nature type stuff. So that is where we use CRP. C-reactive protein also. You can use the CRP also. There are other tests, but which are not used, but if you are really interested, you can just check out this thing called the Zeta Sedimentation Ratio. So nobody does this, but I'm just going to tell you about it for a minute. So remember that your cells have this negative static charge called the zeta charge over here. Yeah, just remember that. Okay, so what happens in zeta sedimentation is, you remember anemia influences the rate of ESR formation. So what if a person comes with like cancer or rheumatoid arthritis, and he also has anemia? Now that's going to affect his erythrocyte sedimentation rate, isn't it? It's going to mess with our results. So because of this, comorbid condition, along with rheumatoid arthritis, for example, a person can get anemia. So is his ESR high or low, or is the anemia influencing the value of his ESR? Like, is the person getting better but he still has anemia, so his ESR is showing a high level? This becomes a confusing thing. It can confuse you into making a decision, or then you might start adding more drugs where you shouldn't. So for that reason, what we do is we take this blood sample over here, and we just centrifugate the blood for 45 seconds. 45 seconds. 4 times, just repeatedly. Just put it in a centrifuge, centrifugate your blood for 45 seconds. And what's going to happen is you start to compact the red cells quickly. In just 3 minutes, you can compact these cells, and you will see that there is a separation again of the cells from the plasma, just like your hematocrit reading. But it's not going to be exactly like your hematocrit, because when we were doing the hematocrit tests, we centrifugated the blood at 3,000 revolutions per minute for 20 minutes, and heck, even longer than that. So this is going to centrifugate your blood, and this is going to compact your blood to a certain amount, but not as much as a proper hematocrit test. And this kind of sedimentation is going to be read like a hematocrit. We call this the Zeta-crit. And this Zeta-crit is we're going to divide this with your hematocrit. So you take the ratio over here. So what we do is the true hematocrit divided by the zetacrit is given, and you get this kind of a value. This is your zetacrit ratio, zetacrit sedimentation ratio. And this ratio helps you to find out if you have certain, if again you have inflammation. If you have anemia, you are countering the effect of the anemia and its influence. So you can find out the prognosis of this inflammatory condition that the patient is suffering from over here. Okay, so the normal value of an adult's zetacrit is around 40 to 50% for both male and female. So these are again rare, but just thought I'd mention it for your benefit. Or there are it's just an interesting point. It's unlikely you would ever see this in your life, but it's just good to know all of this. It's for the concepts, so we understand the concepts over here. Okay, any other interesting points? Your ESR can be decreased, and like I said, polycythemia, conditions where you have no fibrinogen, like afibrinogenemia, then sickle cell anemia, and spherocytosis. Remember hereditary spherocytosis, where the cytoskeleton of the red cell is messed up and not proper, so you can get this hereditary spherocytosis over there. So these are your main conditions you would think of to have a decreased ESR. Okay, so we've done a good job over here, and it's been very interesting to teach this. Causes of increased ESR: TB, cancers, especially Hodgkin's lymphoma, autoimmune conditions like RA, SLE, gout, and then we have conditions like your pregnancies, because they make it causes an increase in plasma proteins. Okay, you get more fibrinogen globulin in pregnancy, and sometimes you get it even after meals. So just make sure, ask them if they had a heavy meal before doing the ESR test, and also anemia. So these are the conditions that can increase the ESR. Keep an eye on these. Be aware of these. These are very interesting topics. Okay, so we'll move on to the next topic in the next class. I think we've done plenty over here. Yeah, see you in the next video.